Welcome everyone. My name is Priyanka Dayal McCluskey. I'm a senior healthcare reporter at WBUR, Boston's NPR station, and I'll be moderating today's discussion on maternal health. I am delighted to be joined by today's panelists, and next to me here is Fifi Diop. She's the Assistant Commissioner for Health Equity at the Massachusetts Department of Public Health. We have Amber Weiseth, Director of the Delivery Decisions Initiative at Ariadne Labs, and Jessica Cohen, the Bruce A. Beal, Robert L. Beal, and Alexander S. Beal Associate Professor of Global Health at the Harvard T.H. Chan School. And joining us remotely from San Francisco is Amanda Williams, Clinical Innovation Advisor of the California Maternal Quality Care Collaborative. So thank you all for being here. I want to start by just briefly painting a picture of maternal health in the United States. The maternal mortality rate here is more than 3 times the rate in most high-income countries. And the research shows that most of these deaths are preventable, and we also see really stark racial and ethnic inequities that have been growing. So there's also a lot of work going on to address these problems, and our panelists are at the forefront of a lot of that work. So first, I want to just ask, why is the U.S. so far behind other high-income countries? And I'd love to hear from each of you. Do you want to start us off, Jessica?
Sure, thank you, Priyanka, for this important question. I would say the reason that the U.S. maternal mortality rate is so much higher than other OECD countries is as complex and multifactorial as it is urgent. So I'll just focus on one thing to sort of bring it into the discussion, and that is the sort of declining and highly inequitable access to maternity care that we have in this country. And unfortunately, this is a place where we're going in the wrong direction. So to prevent a maternal death, people need access to high quality maternity care during pregnancy. They need access to ultrasounds during delivery. They need a close place to deliver. And for example, postpartum people who have mental health conditions need accessible postpartum care, but many people need to travel very far for these services. And even, this is particularly the case in rural areas where obstetric units are closing, but even in urban settings, some people need to travel for very long times to get across the city on public transportation to the only hospital that will cover birth by someone who has Medicaid for their insurance. And just to add to that, while sort of travel distances are increasingly a problem, so are out-of-pocket costs for maternity care, which is also an accessibility challenge and is also sort of going in the wrong direction. So people pay on average $2,000 out of pocket for childbirth if they have commercial insurance, and these sort of high cost sharing plans are increasing in the US. So I would say both in terms of travel to care and cost of care, we're going in the wrong direction.
Amber, do you want to add to that?
Yeah, I'd be happy to. So the way our healthcare system is set up, it's consistently inconsistent. If I asked all of you the last time you went in to see a provider or to get healthcare, what your experience was like, you probably each would have a different story. And that's not just influenced by who we're seeing or where we're getting care, but things about us, what we look like, where we're from, the language we speak. So we have a system that's built to be structurally racist. It's built to be inequitable, and we have to deal with some of those structures before we're really going to see the outcomes change. In our work, we look a lot about how health systems function. And for teams that work in hospitals, when you have a poor event or an unintended sort of bad outcome, those charts are reviewed. They're called sentinel events. And there's an organization called Joint Commission that they review these sentinel events. And the first time I heard the statistic, it totally shocked me, but then also didn't, because it reflected my lived experience as a nurse. They state that 80 to 90% of those sentinel events have a root cause failure in how teams function or how they communicate. So it's not just that we may not have access or not have all the right systems, but it's that people are not using them, not talking, not listening to patients in the way that they should. So part of why we're seeing these outcomes, and you guys have probably read about this, patients are speaking up, saying they have concerns, they're not being heard, right? That's a breakdown in communication. So I'll pause there because I'm going long. Off to you, Fifi.
Thank you. So for me, the most alarming aspect of this maternal health crisis is the fact that according to the CDC, in the US, Black women die at a rate that is 3 to 4 times higher than white, which is one of the widest health inequities in maternal health. And studies that have examined preventability related to maternal mortality, near-miss events, severe maternal morbidity indicate that inappropriate and incomplete management is usually the reasons. And those include failure to diagnose, poor communication, as Amber mentioned, inappropriate referrals, were some of the most common preventable factors at any point in the mortality or morbidity continuum. I don't know how many people in this room know that in July of 2023, the Department of Public Health released data on severe maternal morbidity known as SMM, showing that SMM in Massachusetts nearly doubled between 2011 and 2020, going from 52.3% per 10,000 deliveries to 100.4 per 10,000 deliveries in 2020. And the most troubling factor in Massachusetts, again, is that Black non-Hispanic birthing people had a rate of that was twice as high for comparing Black and white in 2011. But by 2020, that rate was 2.5 times higher. This is an overall increase of 25% for the past decade. The data also revealed some very troubling inequities for birthing people with intellectual, vision, and mobility disabilities, with rates that were significantly higher compared to people who were not disabled.
Thank you. And Amanda, can you share your perspective on why things are so bad in the data?
Well, as Jessica alluded to, there are many factors at play here. But the one that I want to double click on is our insurance system. So we know that over half of the births in the United States are covered through Medicaid, but the way that Medicaid is implemented at each state level can be quite variable. There's been quite a bit of uptake in terms of extension of Medicaid through the first year postpartum, and we're hoping that we know it'll be part of the puzzle, but compared to our economic peer countries, we have no national insurance. This linking of commercial insurance to work is just a historical relic. That is, a leftover from the 19th century. There's no actual reason that insurance needs to be tied to work. And then on top of it, we know that with Medicaid, people can come in and out of coverage when they move, when they have a work change. That can have very significant impact. In our latest California data, we see that those that are insured through Medi-Cal, which is our state Medicaid, are twice as likely to experience maternal mortality. So when we think about the uninsured, when we think about Medicaid, we have to make sure that when we're innovating and looking for solutions, that we're looking to how our patients are insured and how they're getting covered for their birth experiences also.
Thank you. So I was thinking about the title of this discussion about the experience of childbirth. So what is a good birth? What is a good birth experience, or what should we be measuring to really quantify this? And I'd love Amber to start off, since you have all that experience as a bedside nurse.
As we were getting ready today, I was talking about my favorite birth stories. I'm a labor and delivery nurse, and so I took care of families at the bedside for 14 years before moving into this role. And I have a Rolodex of all of these really incredible births, both good and also some hard ones. When I was trying to isolate down, like, what is it that made the good ones good, there were a couple things that came forward. And actually, safety was sort of secondarily to these emotional perceptions of, like, trust. Not safety, like a clinical outcome, like how they delivered, whether it was a vaginal delivery or C-section, was sort of secondary to the more important thing was feeling safe in the space, feeling like you trusted your team, feeling like you had autonomy, and ultimately that you came through, no matter how hard or easy your birth was, that you came through it feeling empowered, and that you were going to move on through your parenting journey with that empowerment. So yes, that's it.
And Amanda, do you want to speak to that as a clinician as well?
Sure, and it's really tempting for me to say, because I love to DJ my deliveries, a birth with a good, but what that speaks to is that you want the environment that makes you feel good, that you are surrounded by people that you love, whether it's your auntie, your doula, your partner, that it is safe, that it is affirming, as Amber said, empowering, and that it is culturally responsive. So whatever it takes to create that community, and that has to be co-designed with the patient at the center, between the patient, their family, and the hospital around them.
Anybody else want to add to that?
I can. For me, a successful birth is not just the absence of mortality or morbidity, but the overall positive patient's experience, the satisfaction about the way they, the patient, and their families were treated, cared for with respect, dignity, and ability to make decisions while being listened to and heard.
So go ahead, Jessica.
I don't have much to add to those excellent points. I think I'll just add to that that I think of a good birth as also one where people are in a place where they are capable of providing high quality care, and that ends in an alive and healthy and happy mom and baby.
So we've been talking about the rates of morbidity and mortality for Black birthing people are so much higher than for white people. So Fifi, could you tell us more about how maternal care, how healthcare systems can better meet the needs of the communities that really need the care, and where we're seeing these really unfortunately bad outcomes?
Yes, thank you for the question. So speaking about the Massachusetts context, which is not any different from anywhere in the rest of the country, I think in response to the maternal health crisis here in Massachusetts, we've taken a multi-pronged approach focusing on policies, clinical care, systems of care, community engagement and mobilization, and trainings and tools. On the policy side, the Haley Driscoll administration has introduced Advancing Health Equity in Massachusetts. The acronym is IHEM. We're still figuring how to remember that, which is a place-based initiative aimed at eliminating racial but also economic and regional disparities in health outcomes. The initiative is led by the Executive Office of Health and Human Services, EOHHS, in the state, and is starting to focus on two key priority areas. The first one is maternal and perinatal health, and the second one is the social determinants of health, focusing on cardiometabolic conditions that are the leading causes of, one of the leading causes of death. So the maternal health team will look at the best ways to support moms and infants in the period of before, during, and after pregnancy. At the same time, the social determinants of health will examine all the living conditions and societal structures that make a person more vulnerable to heart disease, stroke, and other cardiometabolic diseases. IHEM is supported by the Office of Health Equity, which was established in 2018 and is housed at the Department of Public Health. In addition, on the policy side, the Racial Inequity in Maternal Health was established. A commission was established by Governor Charlie Baker in 2020, and the commission was tasked with making recommendations and providing advice to the governor, the Attorney General, and the Secretary of EOHHS and make recommendations related to improving maternal health and developing a report, which they delivered. I was a member of the commission. We delivered the report. We came up with several recommendations in 2022. And then on the clinical side, Massachusetts has been working through the State Perinatal Neonatal Quality Improvement Network, known as PINQUIN, which is a joint collaborative of neonatal providers and OB providers. They come together to implement patient safety bundles, and we've implemented a number of bundles: opioid bundle, hemorrhage bundle, hypertension, and in 2022, we implemented the equity bundle specifically to focus on addressing the black and white gap. Bundles are ways to, processes that you put in place. They're condition specific, and when they're brought together, they allow to improve outcomes. And then at the healthcare system level, we are working on implementing the levels of maternal care using the CDC Levels of Maternal Care Assessment tool known as LOCATE. With regard to trainings, we've sponsored so many trainings across the state, starting internally with the Department of Public Health, where staff are required to take a 2-day racial equity training, followed by racial equity labs. There are many trainings. On the provider side, we've sponsored the Speak Up training, which is provided by the Institute of Perinatal Quality Collaborative, and we have trained more than 500 providers across 36 hospitals in the state. Last but not least, the department also created a racial equity data roadmap, which is a tool that programs and providers and hospitals can use to better understand inequities and take action step toward making changes toward better outcomes.
We've been talking a little bit about just what is a good birth and the patient's experience, and I'd love to hear more about the patient being involved in decision making about their own care. And one thing I hear a lot in my reporting, I know you all hear this in your work, is many people of color feel they are not heard when they go to a medical appointment. They don't feel like their concerns are taken seriously or that their pain is taken seriously. So how can we better listen to patients and incorporate their voice? And maybe Amber, do you want us to speak to that first?
Sure. I'm going to bridge to one of our further down questions and talk about an initiative that we have called Team Birth. Has anyone in this room heard of this program before? Yeah, a few people. Thanks for sitting in the front row. I appreciate that. Team Birth, when I describe it to you, it's going to sound really, really, really simple, and it's meant to. It's something that it's meant for anyone to be able to do and not be hard to learn. But the thing about it is it changes relationships, it changes power dynamics, and it changes who has a voice, which is why I wanted to bring it up, Priyanka. Mm-hmm. In a lot of healthcare systems, it's really common as the patient for you to be in a room and your healthcare team be out in the hallway talking about you, making decisions about you. And I believe it's in the best interest. They're trying to be good doctors and midwives and nurses, but it's apart from you. And then they might come in the room and let you know what the decisions are. We're trying to shift that and change it. We want to bring all of the decisions and the communication, the transparency to the bedside so that patients are centered in all of that communication. And so that's what Team Birth's trying to do. It's a teamwork and communication solution. It's a series of huddles, and what's discussed is then written on a dry erase board. Think of a large board in the patient room, so that we have an actual closed loop and agreed upon this is what we're all doing. And so we've been implementing this across different states, lots of in Massachusetts in partnership with Penguin, but now we're in about 15 states and 150 hospitals. And I'll just give you a few data points of interest. We've been implementing across the entire state of Oklahoma. The 44th out of 44 just signed up last week, so every birthing hospital in Oklahoma will have Team Birth. And we've been researching autonomy and trust. So comparing patients who don't have Team Birth or don't have that really transparent, open communication, and those that do. So what do you guess? Those that are exposed to Team Birth, what do you think happens with trust? Increase, yes. So we see a statistically significant increase in trust. How about autonomy? Feeling like you have control of the situation? Think it went up or down or stayed the same? Yeah, so you guys know about it. You're my students in the front row, thank you. Yeah, so what we're seeing is it increases. And interestingly, up until like about a month ago, the largest increase was in our non-Hispanic Black population. So the biggest increase in autonomy. Just last week when we ran the data, it was actually our Alaska Native and American Indian population, which is also in Oklahoma and across our country, a really marginalized population. So it's really important to center people's voices. It's really important to slow down and make space and create a structure to hear what's meaningful to people, to hear their concerns and their expertise that only they can bring to that birthing situation. So that's a little bit about teen birth, but always happy to answer more questions later on.
Thank you.
Mm-hmm.
And Jessica, what can you share about just incorporating the patient's voice and trying to better meet the needs, especially of Black and Brown communities?
Sure, thanks. So maybe we'll talk briefly just about elevating patients' voices during prenatal care. And so one of the hard but urgent topics that I have been working on recently is stillbirth, which people tend to think of as rare and unavoidable, but is actually incredibly common. 1 in every 160 pregnancies ends in stillbirth. That's 1 in every 100 pregnancies to Black individuals. And many of these are late in pregnancy, just weeks before the due date. And this is becoming more on the agenda in the maternal and newborn health space is how do we prevent stillbirths? And squarely on that agenda is informing and empowering pregnant people with the right information. The CDC has an awesome campaign called the #HearHer campaign, and some people call it the Use Your Mom Voice campaign. But this is, in particular with stillbirth, this is about sort of knowing when something feels wrong, feeling empowered to call your doctor or midwife or nurse when something feels wrong, and and not being dismissed, right? I think there's a lot that we can do in terms of listening better to pregnant people in terms of avoiding that bad outcome and many others.
Why don't we talk about stillbirth more? I mean, it is rare, but not so rare as you mentioned.
Right.
Why isn't this something that's more part of the discussion?
That's a good question. It's very squarely in the discussion in other countries, in the UK, in the Netherlands and Australia, and it's bubbling up to the surface. In the US, the NIH just announced its first earmark funding for stillbirth prevention, but it just doesn't get the attention that preterm birth and severe maternal morbidity and those equally or also really tough public health challenges are. I think partly, again, because people don't tend to talk about it, and many people think it's not happening as much as it is. But momentum is really growing. We desperately need better data on the cause of stillbirth. We need to learn more about how patient voice and informing patients that this can happen and what to look out for, the role that plays, and I think we're moving in that direction, hopefully.
Great. Amanda, how do we include the patient's voice, especially for the underserved communities that don't always get heard?
So I think to understand this, we have to think about why are they underserved? Why have they been marginalized? This is not an accident. This is not something that the patients did. This is America, which is foundationally built on systemic racism, on 400 years of enslavement, Jim Crow, discrimination. This did not happen by accident. So when you think about, and I'm a big teen birth fan, Amber, when you think about teen birth, and we actually have something very similar that through the California Maternal Quality Care Collaborative, we have been promoting with our hospitals across California. When you think about why that's benefiting non-Hispanic Black patients and Indigenous patients, it's because it takes formal structures. It takes intention to overcome those biases that are just part of being and living in America. I always say doctors and nurses are good people. I am proud to be a physician. I'm proud to be doing this for 20 plus years. But we are still, as good as our intentions are, we are still part of a society that tells us which voices are more and less important. And the voices that our society tells us through media, through the images that we see, through what's taught in the classroom, those less important voices are those voices that are having these negative outcomes. So as much as we want to empower patients, we want to give them tools, we've got to start doing the really hard work of untangling this deeply enmeshed, systemic, though often usually implicit and unrecognized bias that is part of practicing obstetrics. So how do we do that? And two of the places that I always prioritize and that we're trying to do throughout California is on diversification of care teams to include more midwives who are the experts in low-risk care. That's a whole nother conversation about why we need to have more midwives in practice, but to let the experts in low risk who are trained specifically to be more in tune to what is going on with this physiologic birth with the patient, let them lead, to integrate doulas who are community representatives, giving that social, emotional, physical support, more likely to be culturally concordant with the birthing person, be a part of that team. And then diversification of the physician and midwife workforce vis-a-vis language skills and race ethnicity. I mean, what percentage of American physicians are Black women? 2. Not 12, not 6, not 10. 2. So until we get there, and I would love to see, and of course in light of the recent rulings around affirmative action, this becomes more difficult, and we have to really think about how to do this strategically, but we need diversification of the workforce by race ethnicity for certain types of providers, and then inclusion of other types of clinicians and support people at the table, and then the structures to have collaborative patient-centered discussion around especially decision points like C-section and other elements of the birth that can have a significant morbidity.
Thank you. So the COVID pandemic definitely put a spotlight on inequities across healthcare that have been there for a long time, and it seems like more people are paying attention now, hopefully. But I'm wondering, what lessons do you think we learned about maternal care, maternal health during the pandemic? And although the outcomes got worse for a period, unfortunately, what about any bright spots too about what we learned in terms of remote care, maybe blood pressure monitoring? So just what are your kind of takeaways on lessons learned from the pandemic and how we can do better maternal care? Jessica, do you want to start us off?
Sure. I'll start with the bright side, or I'll focus on the bright side, I think, which is that I think we realized that the prenatal care schedule that we've had for maybe 100 years need not be the same way that it's always been. You don't need to go in constantly and spend, I don't know, many of you who have been through a pregnancy episode know it's like a full-time job. You spend so many hours going back and forth in-person care. And so there is a movement toward right-sized prenatal care, right? So some people don't need to come in all the time for in-person visits. So really this realization that some people are not getting enough care, and some people are probably getting more than they need, and that we can create like a more flexible various modalities of the prenatal care schedule that incorporates virtual visits and some virtual monitoring to make this easier and more efficient.
Go ahead, Amber.
Well, I was just thinking that I told you guys already that I'm a nurse, and nurses are incredible innovators. And I didn't know that for a lot of my career. I just thought we were really sneaky and we were good at making workarounds. But now I know there's a much more positive word, and it's innovator. But I think one of the bright sides of the pandemic is it really forced and brought to light innovation. Thinking about not only prenatal care and rethinking it, but has anyone here had a telehealth appointment since the pandemic? Like, we didn't do that 4 or 5 years ago. So it really has pushed innovation, especially in the use of technology. I think it's also highlighted, it's because things got so much worse for pregnant individuals and birthing people, and especially for Black and Brown, it's really helped to highlight and champion the need, the really urgent need to address some of these issues. And then, actually, I'll stop there, Fifi. Go ahead.
Yeah, so like you said, there was nothing new that we learned related to inequities, but the pandemic did put a spotlight on inequities. And the innovation piece is extremely important. In Massachusetts, for example, when I look at the data, 10% of pregnant people have hypertensive disorders. And when you look at the Black non-Hispanic, 75% have medical complications as a cause of death, and about 47% have hypertensive disorder documented on the death certificate. Now, what we've done is to implement remote blood pressure monitoring pilots in the state. And we are learning that they're extremely helpful for patients to get care right at home while they're taking care of their babies. And we've gotten some really nice quotes from all the patients that are participating, both in English and Spanish, in the Springfield, Bay State area, and in Boston. I think given that maternal death typically happens in the postpartum period, in the first few days or month after birth, it is important to have those type of programs to allow us to monitor patients remotely while keeping them safe, but also being able to deliver. There are some really cool models where they don't have to do anything. The pressure is taken, the reading is provided to the provider, and then any red flag, they get their medication delivered to door, even when they're homeless. As long as they have a phone and we can track them, they get their medication delivered. How cool is that?
Great, thank you. Amanda, lessons from the pandemic?
Well, certainly I would co-sign on all of the remote patient monitoring, which we're huge proponents of in California in the Kaiser Permanente system that I came out of, that I lifted up during the pandemic, of virtual care, of right sizing, and I think also being more honest and open about health outcome disparities. COVID showed us how different communities were impacted, how trust had been eroded in the medical system, and it was something that was traditionally swept under the rug. Some of us have been, yelling about it for years, but kind of falling on the Charlie Brown teacher. Amanda's going to say something about disparities, something about racism. And then now people are saying, oh, yes, wow, this actually really is happening. So I think those elements would be the positive side of the COVID-19 story.
I want to make sure that we talk about doula services and the expansion of access to doulas that's going on in many states, including here in Massachusetts, just getting underway for the Medicaid population. So, Fifi, can you just briefly tell us, why is Massachusetts investing in doula care?
Well, as we mentioned earlier, doulas provide emotional, physical support to their patients. While they're not clinical providers, they do support health outcomes for the mother, the newborn, during and after pregnancy. And it's a nice way for at least the people of color to mitigate the harms that are caused by the healthcare system when they're receiving care. But doulas need to be paid. And we here in Massachusetts are exploring ways in which we can use our Medicaid program to pay doulas. In fact, as of December 8, 2023, Mass Health, which is our Medicaid program, is now covering for doula services, which will allow Mass Health beneficiaries to have doula care. I think typically when Mass Health does something, the private providers will follow. So there is a hope that we will expand it across the state so that anyone who really needs a doula or wants to have a doula can have access to doulas without worrying about payment.
Amanda, you have a bit of a head start there in California with the use of doula services in Medicaid. So tell us the experience there. What have been the obstacles in getting this off the ground?
Well, it was a ton of work making this happen across the state of California, and we had fantastic work groups with different stakeholders, especially from the doula community. And even though it's been over a year since doula services have been covered by our state Medicaid, an incredibly small number of claims have actually been submitted. So we really want California to be a warning to the rest of the country that you can't just say, okay, Medicaid's gonna cover it, everything should be fine now. There actually has to be some real attention put into implementation and into reimbursement amount. So that's a huge piece of the puzzle, is making sure that it is a livable wage for doulas to be able to do this work. So in California, we just increased as of a couple of weeks ago to have the highest reimbursement in the country. Also, the administrative challenges for doula enrollment. These doulas are typically people who are very community-centered, birth-centered. They are not about spreadsheets and billings and forms. And the administrative barriers have been a huge blocker to lots of doulas for becoming Medicaid certified. Further, there's long payment cycles. A lot of the doulas are living essentially paycheck to paycheck, and so they can't wait the 60, 90 days for the billing to take place. And then there needs to be some sort of public service campaign. There needs to be strong relationships with community-based organizations to get the word out. Folks don't know that this is available to them in many circumstances, and they don't know the ways in which it can be beneficial. So there are a lot of implementation challenges that we would certainly, it's great to see we now have 12 states in DC who are covering doulas for Medicaid patients, and we have to make sure that the implementation is done in a thoughtful manner.
So there's a lot of different efforts going on in Massachusetts, around the country, a lot of people working on these issues, but it seems like there's pilot projects that may be happening in silos. And so how do we bring that together? How do you standardize care, or make it improve care everywhere when you have different policies by provider system, by insurer, by state? What's the role of government, or any other thoughts on just how to operate out of silos? Who wants to start?
I feel like you almost are asking us a question that's like, what's the meaning of life? That's a really, really complicated question. I guess I want to add on one thing that it's not the full solution, right? I think the full solution has to really be a combination of community, of healthcare, of policy. It's got to be everybody working together, everybody towards the same goal. But I wanted to add into Amanda's points on doulas because I fully believe in the power of doulas. The evidence is very, very clear, but it is a workforce issue, right? We don't magically have hundreds of thousands of doulas that can be at every birth, and we've created structures that make it harder for them to be paid, and so we've got a lot of work to do there. But I also want to be careful that we don't put all the responsibility on the doulas to fix all the things you mentioned, because if the health system, what we talked about before, already doesn't communicate well, and we know how structures in place that are really promoting hierarchy and not having a voice, if we put doulas into that mix, will doulas be successful? Probably not. If I was a doula thrown into that environment, I might do it a few times and then stop being a doula. So I think we really do have to be really thoughtful in how much ownership we put on doulas to be the solution, that we all see that we need to come around them and make their job easier so that they can have the impact that we know that they can have.
Let me jump in and say that is something that we're working really hard on in our community birth project at the California Maternal Quality Care Collaborative, is working with hospitals to think about how do they collaborate with the local doula organizations and sharing best practices around the state, doing webinars to bring people together to think about what policies do you need to have in your hospital? How do you create a more collaborative environment for doulas? And to pay attention to the fact that the doulas can't be the cure-all to everything. If you don't have good mental health support or good lactation support or good nutrition support, and the doulas trying to do a little bit of all of that, plus care coordination, plus psychosocial support, I mean, I think that we have to be really careful about overtaxing the workforce. And we know that there are huge burnout issues with doulas. Going back to the silos question, there's a whole series of HRSA grants that were just announced recently, and we're proud in California to have one of them. And what it does is bring these entities together. So we have CMQCC, which is the California Maternal Quality Care Collaborative, DHCS, which runs our Medicaid program, California Department of Public Health, and it brings us all together and forces us to collaborate. And I think that those sorts of efforts, so that there isn't so much doubling and rework of similar issues, I think is going to make a big difference.
So I know we're coming close to the end of our time here, but there's so much work to be done, and I'm just hoping that each of you can speak to what's one simple, maybe not simple, but one quick or simple or one thing that you would love to see happen tomorrow that could help pregnant, birthing, or postpartum people. Like, what's on your wish list that you'd love to see change overnight? Jessica, want to start?
Sure. As I mentioned earlier, it's not so easy to be a pregnant person. It's a lot of hours. There's a lot of waiting. But it's as hard as that is. It's probably even harder to be a postpartum person. You're sleep deprived. You have a newborn. You're recovering from delivery, and we don't currently do very much to make postpartum health and well-being. It's not at the top of our to-do list. And one of the things that I think we can do a lot better on is helping people after delivery transition to the care that they need throughout the postpartum year and beyond, transition to primary care, to mental health care, to specialty care, and just take some of the burden off them and helping them transition to other care after delivery.
So my magic wand answer would be, and I really have a lot of obstetrician friends, Amanda, nothing personal, but my magic wand would be that we would have a midwifery care model for our healthcare system. But that's a bit of an ask. So my secondary thing overnight, we have been implementing team birth within a nursing program and within a residency program. And so we're standardizing the learnings of you're learning your skill, how to measure blood loss or do suturing or deal with an emergency. But you're also learning it in how do you have these patient-centered conversations. Doulas are on the training team, so they're giving feedback. And I have just been so encouraged to see the different skills that are being learned by training communication early on. So if I could do anything overnight, it would be all the schools would start doing this, and that providers would learn how to be good listeners early on.
Well, I don't think it's one thing. It's multiple things that need to happen, but I had picked increased access to midwifery and doula care, and potentially more birth centers. In the last decade, Massachusetts has seen a lot of hospital closures, which, to an earlier comment before, talks about the distance people have to travel to receive care. So having more birth centers and building on the midwifery workforce could be one way. It's not one solution. Could be one way we can improve access to care and outcomes.
What's on your wish list, Amanda?
I agree with all of the colleagues, and it's certainly hard to pick one thing, but if I could pick one thing, it would be for every newly delivered person to have a 2-day clinical touch point. So whether that's in their home, whether it's virtual, whether it's, I prefer it not to be coming to a clinic, but I prefer it to be the virtual or a home visitor, to have a clinical touch point 2 days after leaving the hospital. Because it's such a critical time that postpartum, as Jessica stated, is absolutely brutal. We know that in that first 42 days postpartum is when most of the maternal deaths happen. If we can just get folks on the right spot in the decision tree, what kind of follow-up do they need? Are there issues with baby? Are there issues with latch? Are we checking blood pressure? There's so many things that happen in those early days postpartum that if everyone could have a touch point a couple days after they leave the hospital, I think that that will set that new family out on so much more of a positive course.
Great. Thank you. So unfortunately, that's all the time we have for this discussion. Thank you so much to our panelists. I learned a lot. I'm sure our audience learned a lot from your comments. So thank you, everybody, and have a great afternoon.